Okay, thank you very much, Tiffany, and a very warm welcome back to this afternoon session. For those of you who are joining us virtually from elsewhere in the world, very good morning, good afternoon, good evening, because we know we have about 400 over participants from Asia Pacific all the way across the world in North and South America. So we are delighted that you can join us for this Surgical Oncology Symposium organized by the National University Cancer Institute, Singapore. This afternoon will be a Symposium 2 on minimally invasive surgery and robotic surgery. And it is my honor to chair this session together with my co-chair and good friend, Prof. Tan Ke Kan, who is the head of colorectal surgery at NCIS. So we will have 3 lectures, followed by an afternoon break, and then followed by 2 lectures. Each of these lectures will be delivered by eminent speakers who are all key opinion leaders in their respective field. So let me just introduce the first speaker, who is Professor Koon-Ho, who is Professor of Urology and Robotic and Minimally Invasive Surgery Center at the Yonsei Da Vinci Training Center in Seoul, Korea. Professor Ra did his urological residency at the Mayo Clinic and subsequently underwent fellowship training in minimally invasive laparoscopic surgery at Johns Hopkins, and subsequently served as a visiting assistant professor in urology at Johns Hopkins University School of Medicine. Professor Ra set up the robotic surgery program at Yonsei University, and as we all know, this has now become the most successful robotic surgery program in the world. And Prof. Ra himself has performed personally more than 3,000 cases of robotic surgery. He has published extensively with 280 peer-reviewed publications on minimally invasive urological surgery, and certainly is a key opinion leader internationally in the world of robotic surgery. So he would be the best person to speak to us this afternoon on the advancements in surgical robots and the future of robotic surgery. Professor Ra, please.
Thank you for the kind introduction. It's so nice to be in Singapore online. I hope everyone is well and healthy. I've been just tested for COVID-19 yesterday for travel to US this weekend. So I think for next year's meeting, I hope we can see at the NCIS and all the friends in their native home hospitals again. It is my great honor to speak about the future of robotic surgery. One disclosure is that I moved from Yonsei to the company called Align and Naver.com, which is an internet service company, and lead healthcare. As introduced, we started robotic surgery at Yonsei in 2005, and more than 30,000 cases has been performed. And I know our chairman, gynecology, general surgeons, colorectal surgery, fairly well represented. And I think today I'll speak more about in detail what are the history and future of robotic surgery today. I'm a urologist, so we do prostatectomies and partial nephrectomies. As you can see in purple, that all the major procedures at Yonsei has been performed robotically now. So I think it's a matter of progression. So the computers have been progressed, as you see here. The cell phones as well. But I think the robots is the same. Once I see the robot today, I think it will be probably the very old cell phones or the car phones that we carried around some 20, 30 years ago. So I think the robotic surgery, more than 20 years now, has become and served more than 7 million patients worldwide. But it started from this. And I think what is in store in future is very exciting for us. So these are the future that I envision. And many of us know that now is commercially available today. So one of the key concepts introduced by the Italian group was the Alphex project. Now it's a US company available commercially. And this robot is actually available in many parts of Latin America today. So it's a very cost-effective robot. Many things are, the disposables are multi-use. So you can use 10 times. So the cost of robotic surgery for this platform is about $600 to $700 US. And we heard so much about the Titan Medicals over the years from Canada. I think their platform is remained to be seen, but I think their option is very valid, and we look forward to see more options coming from Canada as well. And this is a robot that's available in Singapore, and many of us use as an ENT world. I think, so this is a concept that you can use many different robotics in the world. One caveat is that this robot is quite expensive because the entire package is disposable. The Mako robotics has been very popular down under Australia, and now gaining popularity here in Korea as well. So now you do not have to remove the total knee. You can do the unit knee replacement, which means that you can replace the portion of the joint. So it will greatly increase the longevity of the joints. And there are various robotic platforms in the orthopedic world. So I go to some of the robotic symposiums now that orthopedic colleagues, and I'll show you in a moment, that neurosurgical friends are enjoying robotic surgery as well. So this is the neurosurgical robot, the spine robot that Mazur developed from the Israeli group. And this is introduced with the C-arm. And this can increase the longevity of the implants because it's so accurate than done by the human hands. There are many new developments in cardiology as well. You can use a cardiology interventional robotics. Now there are 3 different companies doing these robotic procedures for cardiology. We all heard about this EMR. I think this is an exciting technology from Great Britain, and now it's available in India and many parts of Europe. And now it's being launched in Latin America as well. So this is another very compact system. And it's all hand control. It doesn't have the pedals. So the movement are more exact in this type of robot. We heard about the project initially started from the Google with Ethicon friends at J&J. And now they're trying to launch this robot. I think the speculation is that there will be more than 4 arms in this robotic platform. And this endeavor is now being headed by Dr. Fred Moll, the founder of Intuitive Surgical, who's a surgeon himself. And I think it's very exciting that in US market, now there are a few other options other than Intuitive Surgical robot, which we perform more than 20 years, will be available very soon. Here in Asia, I think there are other options as well. This is the micro hand from mainland China. Now there are 3, 4, 5 different companies making surgical robotics in the mainland China. And prototypes, I think, is very well made. And now, since last year, the Kawasaki robot, Hinotori, is available in Japan. This is made from Kobe, Japan. And this has a very compact footprint and has a great vision. I think it's the full HD plus 8K vision. So I think this is another option that the robotics are available from Asia as well. But there are other options in the surgical robotics as well. As you can see, these are the KUKA medical robot developed from in Germany, now owned by a Chinese company. This is a robot you can do the biopsies. You can do ultrasound, which is seen here. So if you are doing a RF or HIFU procedures or biopsy procedures, it can be combined, as you can see here, with the C-arm and integrated by full 3D images. So you can custom made these robotic systems to perform and suit your needs for surgical robotics. For the rest of the talk, I'd like to introduce about the experience in Korean robotic platform and the new exciting platform and experience we experienced in Korea about the SP Da Vinci surgical platform. First is the Korean surgical robotic platform that I did a principal investigator for 10 years and now available in Korea and many countries. So this was a great joint effort by many different companies. And then it took us more than 10 years. And it comprises of a same surgeon console, vision card, and operation card. If you are contemplating developing surgical robotics, I think you have to do the same old clinical trial, starting from the animal labs, some of the pig labs, followed by chronic animal studies, and then afterwards you have to duplicate and satisfy your governing bodies like Korean FDA or US FDA to approve this robot. So this is one of the early experience we did for a Korean FDA, how we could do the similar procedures with Da Vinci training module with the Korean robot. So just 5 years ago, after the grant from the Korean government, we did the first successful robotic prostatectomy case. I think the clinical trial, now the post-marketing trial is going on. And in Korea, there are many institutions doing surgical robotics, mostly in gynecology and general surgery. So this was a very first case we did. Those of you who are not familiar with this robot, this is very similar to Da Vinci SI robot. So the port placement is similar. We didn't know initially what this carries implication for surgical communities. That one thing was very nice compared to CMR and other surgical robotics that I test drove is that you do not have to learn this procedure all new again. What I mean is that you can do this procedure just the way you drove the Da Vinci surgical robot. The surgical procedures by the nursing crew, the cleansing, and everything else, including anesthesia, was the same. So that was a great benefit. We didn't realize initially that becoming similar to the Da Vinci surgical robot has a great value in our initial experiment. So if we go back to the very early case, this is the early procedure. Those of you who are not familiar with the urological procedures, this is the Regisparing area, which means that Douglas pouch, this is rectum, and this is pubic bone, and make a incision. And you can, as you can see, it looks very similar to Da Vinci surgical robot. You can utilize your clips, you can needles, but this is, as you can imagine, this is a prostate, rectum, very small area. So I was worried about this procedure initially, so that the Korean government and I and our institutional board at Yonsei has developed a triplet safety system, which means that one Korean surgical robot was standing, second surgical robot was in the corridor just in case the first one breaks down, and a Da Vinci surgical robot was standing as well, just in case both new Korean surgical robot fails. Fortunately today, that didn't happen. We didn't even have to bring in the second robot. Even the day one, we were very fortunate that we could carry out these procedures just as the Da Vinci surgery. Those of you who are experienced in Da Vinci surgery will notice that it looks slightly slower. Yes, it is. It is slightly slower. The newer version, after 5 years, has a greater vision, I think, than Da Vinci SI. Is it better than Da Vinci XI? Maybe not in many ways, but I think for the vision-wise, I think now with the full HD vision, the Korean robotic system, I think does have a value in its place. So the initial series has been very enjoyable. The surgical time was about 3 hours. I'd like to stress that the docking time was just 10 minutes. Let me ask our surgeon colleagues, what is your docking time today? I think 10 minutes is a reasonable time for the Da Vinci surgery, or I'll show you in a moment about my SP experience, single port experience. Docking time actually takes slightly longer for the newer robotic systems. Console time for prostatectomy was under 2 hours. At the latest, I finished less than 60 minutes, 1 hour, and the complication was minimal. So rest of the 10, 15 minutes, I'd like to discuss about the utilization of the Da Vinci SP. I'm not sure how much is available in other parts of Asia or other parts of the world, but I think you can see what we have done using the Da Vinci SP platform. This was the second robot in the world after Cleveland Clinic, which the initial clinical trial has been performed. So we've been very fortunate. We have 2 Da Vinci SP robots today, and we're thinking about getting the 3rd SP robot. So I think very quickly at Yonsei, everything is moving from conventional multi-port XI surgery to SP surgery. So I think within 3 years, we culminated more than 1,000 cases with Da Vinci SP cases. And I'm sure many of us are curious who uses this platform. Number 1 utilization was ENT department. And the second was a thyroid. And other new indications, surprisingly, like the breast or hepatobiliary surgery and OBGYN and urology and plastic surgery even were among the utilization, the partners of Da Vinci SP at Yonsei. Let me briefly introduce how we use at the urology, including pediatric area. So the first case was performed about 3 years ago, and the first case was the partial nephrectomy. And then we did the partial nephrectomy, pyeloplasties, neocystomies, and other cases at Yonsei. First was a partial nephrectomy. This is a surgery on the retroperitoneum, the kidney. So utilizing 3.5 centimeters. So I'd like to show you our left and right cases simultaneously. So you see exactly the same, but it is like having a sandbag around your the ankles. So you're slowed down because when you have to mobilize great distances, this actually slows you down a little bit. You see on the right-hand screen, the renal artery is pulsating, but using the Da Vinci SP system, there's a progress. You can use the holding threads, and you can use the ultrasound that you see here. You can demarcate the tumor. You can use the clamps, bulldog clamps. So this is everything you can be duplicated that you've been doing all your life with laparoscopic surgery and multi-port Da Vinci surgery can be performed. And those of you who are curious, then what about suturing? Yes, I think the great fear that I had about this Da Vinci SP surgery is that since this is a smaller instrument, would it have a big enough traction forces and the grasping forces to drive needles and doing counter tractions? Yes, it did. I think this is a engineering marvel, and the scope, even though it's much smaller than the multi-port Da Vinci surgery, the vision as you see here is a phenomenal HD vision. So I think my hats are off to Intuitive Surgical about bringing this fancy instrument with the vision system with the Da Vinci SP. What about the pyeloplasties? I think you can do pyeloplasties. There are similar procedures in general surgery, Nissen fundoplications, and other procedures, simpler procedures you can do. This is great because it only has one hole. You can use a gel port device to mobilize these areas. So the pyloplast, we gained experiences by 3 different young surgeons. And then we move on to the pediatric area. Can it be used in pediatric surgery? We learned many things about pediatrics. Maybe it wasn't as great that we thought because it did have a working space requirement. So if the child is too small, it was difficult to use. But we found an indication if the child is probably slightly bigger than 1 meter, 100 centimeters, then you can probably use this robotic system as we have experienced in the partial nephrectomies and adult pyeloplasties. Once again, the suturing is phenomenal. You can do all your instruments that you've been using for other surgical robotic platforms. So if you see the pediatric cases, the smallest, the kid was 110 centimeters, and the operative time was just under 3 hours. The consult time was anywhere from 85 minutes to 2 hours. So I think feasible for taller than 110 centimeters SP. Those of you who are in pediatric world, please think about this as probably the size of the patient or the child that you'll be thinking about adopting SP surgery. Rest of the surgery, I'd like to discuss about the prostatectomy with SP. As we all know, the Da Vinci gained great fame from the prostatectomy world from United States. And naturally thinking that maybe it's feasible doing the prostatectomy, the SP, the platform. So this was a very early series from Mayo Clinic. And there are many different ways to do a prostatectomy. There's a perineal, the very first procedure. There's a retropubic, open, and there's the Regisparing. So there are many different ways we can do a skin a cat or remove the prostate. So the first thing that open surgeons did more than 100 years ago was a transperineal robotic prostatectomy. So the first clinical report has been performed from the first institution, Cleveland Clinic, by good friend, Dr. K. Yoke. And then this was a perineal prostatectomy. So those of you who are general surgeon, our chairman, colorectal surgeon will be very familiar with this area. As a urologist, I'm not very familiar. So I had to relearn my procedures. So making a semilunar incision and then the central tendon, I must admit, it was the first time in my life to see the central tendon. And then we had to place the gel port and SP docking. And afterwards, it's a smooth sailing. The prostate is prostate, anatomy was anatomy. But as I mentioned in the pediatrics case, you have to have enough space between your instrument and the prostate or this perineal area. In Korea, there's other groups who are doing transanal procedures with Da Vinci SP, Samsung Medical Center. And I'm sure many are exploring various ways you can use SP surgery. So this is the view of doing a prostatectomy at the apical area of the prostate. And this is the urethra. And you see the Foley catheter here. And then you can, after that, you can remove the bladder neck. And then the prostate is out. After the prostate is out, you see the urine from the bladder. And then you do the suturing, as we think that the Da Vinci surgical platform always has been a good friend when you're doing a laparoscopic procedures. So I've done 3 perineal prostatectomies using Da Vinci SP. First case, second case had a significant story of abdominal previous surgery. So one patient had a fecal diversion. The second patient had a total colectomies. And the third patient, I got confidence and I explored this patients to do a perineal prostatectomy. And the operative time was anywhere from 3 hours to 4.5 hours. It was longer than my conventional procedures. And I concluded after these cases, it can be done, but is it really feasible to do the perineal prostatectomy compared to the other ways of doing prostatectomy? I had slight reservations, so I stopped performing these procedures. Lastly, I'd like to speak about the Regisparing procedures. I've done more than close to 2,000 cases. And my hats are off to my good friends, Jeremy Saw, Eddie Chan, and Anthony Ng in Hong Kong Chinese University, who has done the first case using cadaverine model 3 years ago. So Regisparing surgery is a trans-abdominal, the Regisparing surgery. So it requires a 15 degrees of tilt. And then you make a 3 to 4 centimeter supraumbilical incision. And everything is same for the gel port placement. And then you try to mobilize the bowel because you have to see this the Douglas pouch area. So once you see this area, you make an incision, then you identify the vas deferens and seminal vesicles. So this is a very straightforward procedure. And then afterwards, you can do a lateral dissection of the prostate and apical dissection as well. So we call it, this is a reverse perineal prostatectomy. So it looks very similar to the video that I showed you with the perineal prostatectomy, but it's reversed. I'm seeing from the abdominal side rather than perineal side. So this is a reverse perineal prostatectomy so that you can do all the nerve savings. You can do a very nice prostatectomy with this series. And at the end, you have to conclude by doing a bladder, which is up here still, and then doing a anastomosis using a barbed wire sutures. So what was my lesson? The operative time was reasonable. The consult time was around 1 hour. There were minimal complications after 10 cases. So I think this is a doable case with the Regisparing, and the patient's recovery, I cannot explain today, but was faster. Maybe it's because of the less ports. And the neurovascular bundle savings and the functional outcome is at least at par, same as previous prostatectomies. But I think, is it better? I think it remains to be seen. So I think many groups who's doing a SP, Regisparing, or other prostatectomy will provide an answer, perhaps after COVID-19 world. Lastly, I'd like to show you a very innovative platform from Intuitive Surgical. Actually, there's another company, Auris, which now has been acquired by J&J Ethicon, doing a transbronchial biopsy. There are 2 different types. So I showed you about the Hansen technology. So I think these Auris, all these technologies are driven from guide wire moving technologies. So you can do a transbronchial biopsy, as you can see here. So you could do, in theory, you could do lung ablations in suspicious SOLs, the solitary lung nodules, to ablate and biopsy the bronchial, transbronchial lung lesions. I'd like to thank all my friends over the years who developed these procedures for us. Many robotic platforms are on the horizon and available. Many are under clinical trials. Some are in the market, post-marketing studies. All these competitions will be more beneficial to the patients and surgical community. The last note is that in Korea, there are more than 120 Da Vinci systems installed. There are the handful of the Korean robotic platform as well. The one good thing for the surgeon is that the cost become less for the Da Vinci surgical platform as well. So competition, I think, is good for everyone, including for our surgeons, our patients, and the community as well. Lastly, I'd like to thank all my fellows and friends over the years who came to Yonsei and helped this program and experienced great surgical robotic systems. So once again, thank you very much for today's opportunities. Please stay healthy And we look forward to see you next year in Singapore National University Hospital for in-person meeting. Thank you very much.
Okay, thank you very much indeed, Professor Ra, for that brilliant chronicle of the entire surgical landscape of the history, present, and the future of robotic surgery in surgical oncology, with the illustrations and videos using urology and prostatectomy as a great example. So we have time for questions from the audience, both from here as well as those who are joining us virtually. Yes, Jimmy.
Thanks, Jeffy. Jimmy So from Singapore. Thanks, Professor Ra, for sharing your vast experience of robotic surgery to us as general surgical communities. I have two questions. First question is for your the Korean robot, the Vivo one. I was very impressed with your docking time and the size. Is what make the tricks? What are the difference between the Vivo one versus the conventional Da Vinci? What's the difference between the Korean robots compared to the Da Vinci robots?
Yes, the docking time was similar because it basically was a copy technology from Da Vinci surgery in surgical, instruments. Docking time was similar because our group was experienced with more than thousands of robotic surgery, including my fellows and nurses. So that was a great advantage for us actually, because we did not have a learning curve as a team. So, but if you are using a new surgical robotics from other companies, I think there should be a training issues, and you have to spend a significant portion of the time to familiarize you and yourself with the new surgical robot.
Yes. I have a follow-up questions. Yeah, my follow-up question is on Da Vinci SP. I mean, we have been doing single port surgery versus multi-port surgery about 10 years ago. And we noticed that single port surgery, they also have their own problem, not only the ergonomics, because the wound is significantly bigger, larger than the multi-port surgery, and this wound of 3 or 4 centimeters may cause some problem like post-op wound pain, wound infections, or incisional hernia. I just wonder what's your envisions advantage of Da Vinci SP?
10 years ago, the laparoscopic surgery, multi-port and single-port wound was a problem. Briefly, yes, I did the single-port surgery laparoscopically. I even did the multi-port Da Vinci single-port surgery with gel port. So the wound was, actually the time was much longer to make an incision, getting the gel port. Even today, I think that's the #1 issue. The preparation time is much longer. But you gain one aspect because your closure time at the end of the surgery is less. So I think the trade-off is similar. The biggest problem I had was the non-intuitiveness, because everything was reversed when you're doing suturing and counter traction. But the SP doesn't have any of the issue. I mentioned in the presentation that the counter traction, the force generated by the smaller instrument is just phenomenal. Secondly, the vision system, 3D vision in the smaller system is phenomenal. So I think it remains to be seen. I don't think it will replace all our surgeries with SP, but we're trying to find out at Yonsei which procedures are suitable and more efficacious, beneficial using the single port robotic platform. Thank you.
Thank you. I think we have time for one last question from Prof. Edmund Cheong. He's asking if you expect that discipline-specific robot to become more common in the future versus multi-use platforms.
Yes, nice to hear Dr. Chung again. I think, as I mentioned just moments ago, it will have its own place. There will be open surgery, there will be laparoscopic surgery, there's multi-port surgery, there's a endoscopic robotics. There will be, and then single port surgery. So I think it will compete in its own realm, own areas. And our surgical communities have to provide data and actual scientific evidences, which is the better. And then those answers will come from Singapore, Asia, probably than other parts of the world, I hope.
Okay, thank you very much, Prof. Ra. So if there are no further questions, we will bring this lecture to a close. Thank you very much. Let's give him a warm round of applause.